So, hello everybody. Sorry for the delay in sending or uploading further lessons recently. So now I'm trying to go through the various questions again in the MRCP exam. So let's have a look. Now I'm trying to improve the quality of the audio. The last lesson, the audio quality was not very good, so hopefully in this video the audio quality is better. So I apologize in advance if it is not very good. So let's start first with a question for a 55-year-old lorry driver. He has a central chest pain. He's feeling of pressure on his chest that is building up intensity. He's sweaty, clammy, so he might have myocardial infarction, vomits in the resuscitation, ECG showing ST elevation in the anterior leads confirming anterior myocardial infarction, following rhythms on an ECG taking 2 hours post-PCI associated with a worse prognosis. Is it multiple ventricular ectopics? So what is the post-PCI in the 2 hours post-PCI? What is the most or the one that is associated with the worst prognosis? Is it ectopics? Is it idioventricular rhythm? Is it third degree atrioventricular block? Is it Mopitz? Well, third block means that it is now affecting the AV node, isn't it? Is it sinus rhythm? Is it Mopitz 1? Winky back? So I would go for a third degree block. Let's see if this is the correct answer. Yes, indeed. So it is third degree block. Why? Because the complete block in the context of anterior myocardial infarction means there is an extensive area of infarction, carries higher risk of in-hospital death. This is indication for temporary pacing. Permanent pacing is almost invariably required. There is a trial as well, charisma trial, which showed high ventricular so it showed high ventricular so it's showing high degree AV block is associated with the strongest predictor of mortality. Okay, so not the same studies examine the effect of clopidogrel and aspirin. So this is a different one from that which examined the clopidogrel and aspirin combination on cardiovascular events. Anything else? How many people are answering this question? It's about 80% are able to answer this question, so it's not something difficult. Okay, that's fine. So this is the first question, and let's answer this as, let's say that this is a good answer. Next question, now we're looking at a 45-year-old woman. She has stage 2 breast cancer, and she was treated with surgery, with chemotherapy, and radiotherapy. So this is triple therapy, isn't it? So the cancer was estrogen receptor positive, progesterone receptor negative. Following radiotherapy, she was given tamoxifen. The patient periods has stopped before completion of the chemotherapy, and she's now complaining of hot flushes. So the periods has stopped because of the tamoxifen. So the tamoxifen, is it estrogen receptor? Is it selective estrogen receptor modifier? So what is the following can be recommended? Is it a replacement estrogen therapy? Is it reassurance? I think you go for reassurance here, I think. Let's see. Answer O is Migestrol. Why? So the Migestrol, because some chemotherapies will induce the medical menopause. The hot flushes get worse with tamoxifen or anti-estrogen therapy. Okay, so although these drugs cannot cause menopause, they can mimic some of the symptoms, okay, which may continue for some time. Okay, so the progesterone in low doses is effective in relieving the hot flushes. Okay, so commonly prescribed drugs. So chemotherapy is inducing the medical menopause, but the tamoxifen is causing some symptoms. Anti-estrogen therapy is just worsening the symptoms, and they don't cause the menopause themselves. So commonly prescribed drugs include Migestrol, that's the trade name Migase, medroxyprogesterone Brovera, and northestrone. So mainly it is a progesterone therapy, isn't it? Some evidence that antidepressant drugs, venlafaxine and fluoxetine, can be effective for some women. They are given in lower doses than when they are prescribed for depression, not expected to have antidepressant effects. Okay, kind of these colors a little bit. So it's fine then. So now we understand that the reason behind giving the progesterone is to relieve the hot flushes. So how many people were able to answer this? It's about 40%. About 30% answered C and 20% answered A. Let's have a look at C and A. C, okay, so this is what we've chosen to say. Symptoms of menopause can be extremely debilitating, so therapy intervention is considered essential. Okay, so that's a good point. Now we understood from answering this question. So a patient with some therapy, anti-estrogen therapy after chemotherapy, so these anti-estrogens will aid and worsen the symptoms of postmenopausal symptoms, and therefore you need to alleviate them as they can be debilitating. Okay, so did we answer this question? I'm gonna say hard. Let's go to the next question. This is for a 24-year-old woman. She was admitted to the hospital with a 3-day history feeling unwell. She's feeling fatigue, erythralgia, and pruritus. She had recently finished 5-day course of antibiotics for urinary tract infection. No other significant pathological history. No significant findings, clinical examination, exhibition of the widespread erythematous rash. So it seems like she has a 5-day course antibiotic for urinary tract infection, is doing something. Okay, and causing rash as well, pruritus, erythralgia. So the investigation showing hemoglobin is fine, white blood cell is slightly elevated, and eosinophilia. So this means it is a reaction, isn't it? Could be Dress syndrome. Okay, platelets fine, creatinine is very bad. Okay, that seems slightly elevated, while the sodium is on the lower side, urea is high, urinalysis, the protein and blood. So it seems that the kidney function is very bad. So what is the reason? Is it autoimmune profile? What is the important investigation to establish the diagnosis of the autoimmune profile? Is it renal tract ultrasound, renal biopsy? I think it's autoimmune profile. But let's see. Oh no, it's renal biopsy. So the diagnosis is tubular interstitial nephritis. Okay, normally tubular interstitial nephritis is with the NSAIDs. The renal biopsy will show interstitial, is gonna show interstitial edema, heavy infiltrate of inflammatory cells, variable tubular necrosis, eosinophilia and eosinophiluria are often seen. Most common cause is that's it, hypersensitivity reaction. So we got this right to certain antibiotics such as the penicillin and cephalosporin. So I thought the tubular interstitial nephritis is mainly from the NSAIDs, but I was mistaken because it can come as well from penicillins and cephalosporins from allopurinol. The condition generally has a good prognosis. Majority of the patients recovering following withdrawal of the offending drug. So this is a good prognosis, and the acute kidney disease can often be managed conservatively unless the patient is uremic. In this case, the patient has some uremia, isn't it? Okay, but let's see what they're gonna say here. Some evidence that short course of corticosteroid accelerate recovery, prevent long-term renal damage. Interstitial nephritis may occur in a chronic form. Okay, so this is a tubular interstitial nephritis associated with eosinophilia and eosinophiliuria. Common cause is NSAIDs, as we knew, allopurinol, and also not to forget the antibiotics such as the penicillins and the cephalosporins. Majority of the patients recovering well by withdrawal of the medication. Short-term corticosteroids can also be helpful. Okay, what about other autoimmune profile might aid in the diagnosis of SLE, particularly as there is erythralgia. Okay, so there is erythralgia and rash, but no eosinophilia in SLE. So that is against our answer. Okay, so how many people has answered the C? About 60%, and those who answered the autoimmune number A is about 10%. So okay, so it's more or less this is lots of explanation about the interstitial nephritis. Let's see what they're gonna say here. This is unusual presentation of classic idiopathic polyarthritis nodosa as acute interstitial nephritis. Okay, so most of acute interstitial nephritis is due to the immunology-induced hypersensitivity reaction. And the idiopathic polyarthritis nodosa unusually can present as acute interstitial nephritis. Okay, that's fine, but you need to know that the heterogenic causes such as the NSAIDs are very common. So when you do the investigation for acute interstitial nephritis, like NSAIDs, you need to do urine analysis, which is showing proteinuria, as in this patient, is showing some eosinophils, but the firm diagnosis is through the biopsy. So even though the urine analysis is showing something, now the chronic tubular interstitial, again, you need also biopsy with showing chronic inflammatory changes. Okay, that's fine. So what is the management? Non-pharmacological, you said the precipitating medication. Pharmacological, you can use moderate dose of steroids like 1 milligram per kilogram, tapered over 1 month. The prognosis is good, and that's it. So lots of explanation you can look at, but I hope you learned a little bit from those 3 questions. So in the coming lessons, I'll try to make them around less than 20 minutes, 10 to 15 minutes, and try to give you some of the explanations. I hope you've learned a little bit, and thank you very much for your listening. Please don't forget to like and subscribe. Wish you all the best. Bye bye.